I have been the one coordinating this webinar series. We're very excited to bring this to you and excited for our speakers today. First off, I want to just let you know that today's the overall webinar series is being brought to us in partnership with the University of Oklahoma STAR Prenatal Clinic and the Oklahoma Department of Mental Health and Substance Abuse Services through a grant funded in part by the ODMH and the state opioid response. And so we're very fortunate to have their support to be able to do this for you, and excited that we can also have it recorded. So we are recording this. All recordings and slides that have been approved will be uploaded after our final series, which will be next Thursday. So sometime shortly after that, we will have those available, and we will send out the link to be able to obtain both the slides and the recordings. And I want to apologize because I have a little bit of a cold going on, so I'm a little bit rough on the voice today. And here's just another reminder. Today we're going to be talking about storytelling and stigma. And next week is our final week. And in the series, we will be talking about perinatal cannabis and breastfeeding. So feel free to share the information with those who you're in contact with. And now I'm going to just go ahead and introduce our speakers for today. First, we have Kaytlin Thompson. Kaytlin has always had a passion for serving others and found her path to being community-based doula work after having her daughter. Kaytlin has been sober for 7 years and serves the substance misuse and justice involved community with a strong emphasis on true understanding, compassion, and love. In her spare time, Kaytlin enjoys spending time with her husband and daughter, anything that involves nature, reading a good book, or cooking. And our second speaker today is Melinda Ramage. Melinda is a dedicated clinician, educator, and researcher based in North Carolina with a commitment to the fields of substance use treatment and sexual reproductive health. Melinda focuses on improving care access and delivery for individuals with substance use disorders, particularly pregnant and postpartum people. Her work is characterized by a holistic, trauma-informed approach that prioritizes the foundations set by the Project CARE program, which she is a co-founder, respect, resilience, and recovery. And she will be talking to us today about perinatal substance use disorder and harm reduction charting. So now I'm going to go ahead and turn the time over while we switch our slides to Barbara O'Brien, who is the director of the Oklahoma Perinatal Quality Improvement Collaborative.
Thank you, Evelyn. I'm so excited to be on this webinar this morning and excited to learn. And I'm excited for our speakers, especially this morning. So it is my honor to introduce our first speaker, Kaytlin Thompson. Kaytlin will share her story with us today about her struggles with substance use and her journey in recovery. Kaytlin is passionate about helping women and pregnant people who use drugs or are in recovery to support them and ensure that they feel supported and hopeful for their future. One of our values at OPQIC is to listen to women and families and be open to hearing their stories so their experiences can inform our work. We encourage all of you to also be open to hearing Kaytlin's story today. Think about how you might make changes in your actions and in the systems in which you work. The purpose of this presentation is not to pass judgment, but to identify and implement actions you can take to help those you serve. It may be difficult for Kaytlin to share her story, and it may be difficult for us to hear. Let us all be open to hearing her words and reflecting on them, and thinking of how we can use her story to improve our practice and empower women and families. Please join me in creating a safe space for Kaytlin to share and for us to learn. Kaytlin, I will turn it over to you.
Thank you, Barbara, for the introduction. I'm Kaytlin. I am honored to share my story today. I did write it down because if I don't, I can kind of squirrel and get caught in the emotions of everything. So I will be reading it off of my phone. If I look like I'm not paying attention to the screen, I'm totally here. But here we go. I am honored to share my story today. I believe as humans, we are storytellers and our stories have the ability to impact lives. Today, I am sharing my story to be the voice for people who haven't been able to share their story. In honor of National Recovery Month, I would like to take a moment of silence for the men and women who didn't make it out of this disease alive to tell their stories.
Sorry, are you seeing Kaytlin's slides? I apologize.
Yes.
Okay.
My early childhood was pretty good. I grew up at the lake, camping all the time, which created my deep love for nature today. Around the time my little brother was born when I was 9, my mom fell into a deep state of depression and her bipolar episodes drove her behaviors, which included drinking heavily. My mom went from a PTA mom to drinking entire bottles of vodka for breakfast. My dad slowly backed away and his absence while physically was present was emotionally non-existent. I ended up raising my little brother. I saw his first steps. He called me mom, and when he fell off his bike, he came running to me for comfort. Countless nights I was up with a baby, and after putting a baby to sleep, I would have to then pick my drunken mom up and help her to bed. I was forced to grow up really fast. By the time I was 12, my parents were going through a nasty divorce, and my home turned into a party home. My mom would have friends over drinking until late hours of the morning. I missed school a lot and forget about someone caring if I got good grades or not. I was essentially left to raise myself. And since my mom let the house become a party house, I also was allowed to have friends over and we would all be drinking and partying all night long. I craved so badly to have structure and someone guiding me. I envied my peers who had parents that wanted family dinners and strict rules regarding homework and curfews. I met my first boyfriend when I was around 12. Next slide. Or you can take it off, Evelyn, whichever one you want. Actually, shortly after meeting him, I ran away for a week and hid out. I had a lot of pain, minimal support, and I just wanted love. He became those things for me. This is when the drinking turned into pills. The friend group I was around made it all seem so normal to go to house parties and take pills and drink all night. I ended up with him for about 10 years on and off. He had been in jail numerous times, juvie a couple of times, and rehab more than 4 times. I had no idea what being addicted to something meant. I thought it was as simple as quitting. I used pills and drank frequently, but at this time in my life, I didn't understand addiction. I would go visit him at rehab and we would write letters. I just never understood why he couldn't function in society like the rest of our friend group, including myself. Until one day he was in my bathroom and I found needles in his backpack in my bedroom and what looked like tar wrapped in tin foil. I beat down the bathroom door and confronted him. I never knew through all the years he was doing heavy drugs like heroin. Like many stories, if you can't beat them, join them. So I did. I was around 18 at this time. Heroin slowly turned to meth, and I scoffed at IV users, thinking at least I don't do that. Years pass, I end up with another guy I hadn't known for very long, and I was engaged to him within a matter of months. At the time, I lived at my dad's house. I really just stayed in between benders to eat and sleep and then go back out and run the streets. My dad came home one day really mad and kicked us out. I had just found out I was pregnant. I didn't tell anyone other than my fiance. I was 20, on heroin, pregnant, and now homeless. More importantly, became hopeless. My life spiraled out of control. I did stop the heroin for the sake of the pregnancy, but started taking Subutex. But I never saw a doctor. I was so ashamed and absolutely terrified. I also just didn't have a clear sense of reality whatsoever. This part of my life is a blur. I had no toothbrush, I slept in parks, I had no shoes, and my family had totally given up on me. Months passed by and the reality of having a baby never settled in. It was a fun thought here and there, but never a reality that really slapped me in the face. Until one day I started bleeding and cramping and started losing clots. My fiance at the time was gone buying drugs. I was in an apartment with 6 other people, bed bug infested, and all of them were on dope. I just wrote out the pain. I don't know why it didn't strike me to go to a hospital. My fiance's grandpa found out about what was happening, and after 6 hours of laboring at home, 5 months pregnant, and now losing my baby, he forced me to a hospital. I don't remember a lot. It was traumatic. I remember his grandpa taking me there. It was dark outside, and the hospital felt dark as well. He dropped me off, and my fiance comes walking through the doors of the hospital as I'm waiting in the lobby. At this time, I still didn't know what was happening. I go in the back, and a nurse takes my blood, and I just remember the way she looked at me like I was the worst person in the world. I don't know what she said, if anything, but she didn't have to. How she made me feel is a memory I will never forget. They confirmed I lost the baby via ultrasound in this dark room on my back. I think they wanted to do a DNC, but they just kept shuttling me around in there with minimal words and sent me to a waiting room alone. And the mix of the staff that was silent but extremely judgmental made me feel so horrible. They didn't explain anything to me, guide me, or offer resources or even a comforting word. I ended up just walking out of the hospital. I didn't have the procedure done, and I remember them calling me numerous times on my way back home. I just turned my phone off and I lost all will to live and started praying to God to just kill me every day. Months passed and I had been in a state of meth-induced psychosis. I was walking down the street with my head down to the ground. I never looked up. I had no will, hope, or love anymore, just a deep sense of despair. I was on the way to 7-Eleven with 70 cents in my pocket, and I go to cross the intersection, and on the ground is this flyer that says, "Dope Turn to Hope." So I pick it up for a moment. That was a seed planted, and I didn't even know it. I read it. I was like, wow, threw it down and kept walking. Months later, I go to my grandma's house. She finally allowed me to stay there on the premise of no drugs. I obviously didn't listen. So I hear a knock on the bedroom door and a cop walks in. I had paraphernalia on me, along with meth, heroin, and Xanax. My first boyfriend was back in the picture. He was nodded out on the bed beside me. Another cop just took him right to jail. The cop that took me to his car said to me, "You guys have been together a long time, huh?" And I was like, "Yeah, middle school sweethearts." They all knew him, and by association, me. But most of the times I was calling the cops on him because he was abusive. And the cop said, "I'll give you 2 options. The first one is a detox center overnight." And I was like, yes, immediately without hesitation. I didn't want to know what the second option was. I didn't care. I had been begging my family for help for months. I will never forget sitting in the back of his car and him saying to me, "This is your chance to change your life." And I just sat there and I smiled and I thought, you are so right. I'm going to do it. And so I went to a detox center. My dad picked me up the next day. I'll never forget him walking in and seeing me in this glass room sleeping on a cot. As soon as I got in the car, he said, "When we get home, you're packing a bag and going straight to rehab." So the first place that popped up when I Googled rehabs was Valley Hope. I went that day. Next slide. I spent the next 30 days making every day count. I knew that my family had to make a lot of sacrifices to pay for me to go there. It was thousands of dollars and they couldn't afford to send me multiple times. I attended every AA and NA meeting that came in. I followed the guidelines and I got sober one day at a time. I obviously had never been sober, so I didn't have a plan on what I would do after. So when I was in rehab and kept hearing of this sober living called Hope is Alive in Tulsa, I figured, well, why not? I can't go back home. So that Dope Turn to Hope flyer that day in the street turned into Valley Hope and then Hope is Alive. When I got out of rehab, I moved into sober living, got a job, and walked every day until I saved enough money to buy a car for $800. I was then able to get a better job, eventually a better car. It took many small and big steps to be where I am. Next slide. Today, I am 7 years sober. I left that rehab and never looked back. I did everything people told me to do. I went to multiple meetings a day. I got a sponsor. I worked the steps and they said, it works if you work it. And I saw these people in these rooms with 20 plus years of sobriety. Excuse me. So I just kept doing what they said to do, and it worked. It was the hardest thing I've ever done, but it was so worth it. I graduated college with a 4.0 with a focus in human and social services. I also graduated high school from college because I was kicked out of every school in my district by 10th grade. I met my now husband at an AA meeting. Next slide. I have a daughter that is 2.5 years old, and I now get the opportunity every day to give back to my community by serving women who are in vulnerable places that just need a seed planted and someone to provide a sense of hope. I did track down the cop a few years ago. He's now a sergeant. I didn't know if he'd remembered me, but his words were the guiding light for me to get sober. I don't think he remembered, but I had to thank him for giving me a chance and telling me to take back my life that night.
Thank you, Kaytlin, for sharing your
Thank you.
story. And there's a picture of Kaytlin and her happy family. And Kaytlin is currently a doula at the Tulsa Birth Equity Initiative here in Oklahoma, and we're very fortunate to have her serving there. Is there anything else you want to share about that, Kaytlin?
No, not right now, but thank you so much, everyone, for listening. And I appreciate the opportunity.
Thank you so much, Kaytlin, for sharing with us today. And just huge congratulations on the changes you've made in your life and how you changed the path that you're on. And we appreciate your support.
Thank you so much.
Yes, thank you for being here. Lots of praise in the chat for you. Great job. And now we're going to go ahead and turn the time over to Melinda if she wants to go ahead and start sharing her slides. Wonderful.
Hey, y'all, can you see and hear me? Kaytlin,
Yes.
Thank you so much. I can't think of a more privileged way to talk about research with having real life experience first, right? Because research is dangerous that way, right? We can really separate our humanness. And so, Kaytlin, I would love to invite you to unmic on any part of what I'm going to go through next and for all of you, but I want to speak directly to Kaytlin. Kaytlin, I wish I lived in a world where everyone who saw your face and didn't even have to hear your story, saw you as a human and gave you respect when they interacted with you. And you, I know better than I do that that's not true. That's not the experience. And then the next level is I wish, like, if that couldn't happen, then I wish the next step would be that when people evaluate, and listen and just learn about substance use disorders, that they'd be able to go, oh man, right? Like, I didn't even realize I had this stigma and I really want to work on that, right? And unfortunately, you and I both know that that is also not what always happens. And so to give us succinct, if you all tune out right after I start talking, just know that I think the goal of what I'm going to present is Kaytlin is a pioneer in helping changing people's minds and challenging what preconceived notions and bias and stigma they have in them. What we're about to talk about is, you know what, if today's not the day to change how you view things, I want you to not cause harm while you're working on that. That's really what this is about. So again, Kaytlin, please jump in on any slide. I would love your comments along the way. So let me tell you a little bit about, I'm part of a wonderful research team. This is Phil and Sarah, who couldn't be here today, but they are my fellow researchers. I want to hold space for you research peeps on the call. I am a clinician who does research. I'm not a researcher who, so that you all probably know there's a distinction. I think I maybe drive my research team that I get to work with a little wild and crazy sometimes, because clinic work and research can naturally butt some heads in some really good ways. But we were funded by Pew Charitable Trust to evaluate a program here in Western North Carolina called Project CARA. And part of that evaluation project, we did this subset of this particular look and how we show up in the charts. So what I'm going to go over today is give you a really brief version of the research piece. So what literature was out there as we were forming our research study, a brief description of our research methods, and then most importantly, the results. And then I've been the maternal health lead on our opioid quality collaborative here in North Carolina. So of course, right, we got to do something with that data. So I want to share with you all today something we've been piloting in North Carolina about how to address where we have stigma and bias showing up in our charts. So I'm gonna end with that today. I think this doesn't surprise anybody on this call, right? That stigma and stigmatizing terminology and language, right? Because those are two separate but overlapping concepts, is all over the place, right? It is very prevalent. And not only is it there in the way we use language, both verbal and written, but it's actually embedded in our policies and practices that affect patient care, right? And so our research aims were really to describe patterns of language used by providers, specifically in this perinatal substance use disorder program that was in Western North Carolina. To give you a larger overview, Western North Carolina serves, it's about 17 counties and about a 200-mile spread. Just to, again, as we cross states, right? I know if I say counties, but then I'm talking about Arizona, right? Like Arizona only has like 6 counties, right? And North Carolina has 100, right? So it's not really apples to apples. So this is a perinatal substance use program that serves approximately 250 unduplicated pregnant or parenting people or postpartum people per year. And what the goal was in 2018 and 2019, one of the program's priorities was really making sure all the providers, right? And it's an interprofessional team. So that's prenatal care providers, licensed social workers and therapists, peers. Our doula system is actually outside of the program, so not in our charting system. So an interprofessional team that all were trauma-informed trained, right? So the idea is we have providers, a provider's team that chooses to be there, gets trained in trauma-informed care and how to implement that as best practice from front to end, right? And this program in particular is a harm reduction program. What that means is perinatal care is not contingent on substance use treatment, right? So one of the mottos of the clinic is whether your last use was 5 years ago or 5 minutes ago, welcome to Project CARA, right? So I want to give you that context of, hey, we really have done a lot of intention in this program around building that focus and that space. How did we do keeping those concepts and putting them into the chart, right? And the hypothesis was, man, if we have all this intentionality and all this training, I bet we do a really good job doing charting that also reflects our trauma-informed care principles and training, right? That was the hypothesis. Spoiler alert, right? I'm going to get to the punchline now. It was not true, right? So that is not what we saw in the results. And I want to share that with you today and what we think we may need to do to address it. So when we say the word stigma, whew, man, that can mean a lot, right? So this is an old definition, and I like to use this old definition because I think it gives respect that that stigma is not a new concept, right? A certain attribute that is discrediting an individual, and that attribute is rejected and stereotyped, right? I did drop here a screenshot of one of my favorite books that describes the stigma and how it shows up in addiction. It's called Stigma, an Essential Guide, right? Great title, by Avery and Avery. And what I really love about that book is that it really breaks apart the nuance of our relationships in multiple spheres. So it's really a biophysical, biopsychosocial, actually, aspect of looking at all the places that we hold stigma. So again, this is one of those points that if you get nothing out of this, I really think checking out this book is super helpful as you look at stigma in patient care. So when we think about stigma, particularly in perinatal substance use disorder, right? Being pregnant or postpartum with a substance use disorder is what we're calling, what is an intersectional identity. That means the stigma is amplified, right, exponentially. There's moral judgment that is around pregnancy, that is around substance use, that's around expectations of being presenting female, of being identified as a mother. There's so much that goes into that. I want to give respect that in our data, you notice here I'm highlighting Dr. Crenshaw's work of the larger definition of intersectionality. I do want to hold space that the data you will see later, 98% of the patients that present in Project Cara are white. And so I want to hold space that this data is actually still not full intersectionality work. So I want to hold space to the truth of that. We know through lots of data and lots of our fellow researchers, right, that healthcare interactions lead people feeling mistreated or having their parenting abilities questioned. And Kaytlin, you beautifully talked about that, right? Those words that you said, I will never forget how that person looked at me, right? That sticks with us, right? And it's so powerful how we present in those spaces. Perinatal substance use disorder, both pregnant and postpartum, right, are subject to specific cultural expectations around motherhood and parenting. And then when people, and again, Kaytlin, thank you so much for sharing this part, when people seek treatment, right, because of federal laws and state laws, there is fear around loss of infant custody or legal punishment. We still are not out of the woods where some states criminalize perinatal substance use disorder. So again, just holding space that this is just the tip of the iceberg of the overlapping stigmas that can present in the, what I like to use an acronym, PSUD, or perinatal substance use disorder space. So that's such a big part, right? And again, I promised you that what we're going to be focusing on is actually a really small part of all of that, is that what if what we write in the chart was really looked at, right? Language in chart notes is important. We know that people have more access to the chart thanks to the Cures Act. And for many substance use disorder programs, they may be under a federal rule called 42 CFR. But again, the old days of we write things about people and never show it to them, those walls are crumbling. And that's important, and important to look at how we were taught to chart, right, when that is happening. Again, holding space that substance use disorder care is highly influenced by the perceived opinion of the provider, right? And how do we know what that perceived opinion is? Well, we know it based off that written language. And then the tangible measure of success of training on language in substance use care is a positive. That means that when we make the intention and time to retrain our brains of what comes out of our fingers, that actually shows time and time again that we actually do get better at it. So that's hopeful, right? So I want to highlight some cool papers that came out at the same time that we were doing our research study. So these are not all perinatal, but they do have substance use disorder in common. The one I really want to highlight, because I'm going to talk about it in a little bit, is actually Park et al. It's an article that came out in 2021 that really identify looking at ambulatory setting, right? So internal medicine in a large academic center, looking through chart notes and finding themes about how the language was crafted around people who also have a substance use disorder. And they identified 5 categories of really these negative themes that we use when we're describing our interactions, as well as our recommendations for care. And again, we're going to talk more about that. But if you want to read more, these are other great articles. Himmelstein and Barcelona are also great supports. So again, for our project, I shared with you, this is the one piece of a larger project, and certainly we're very privileged to have this work. It's about to be published in the Journal of Addiction Nursing. And so you'll be able to, if you really like the data piece, I'm going to give it to you in multiple pages here and within the next 60 days. But in general, right, what we're looking at, we did a qualitative and quantitative mixed method study looking at charts. So in a time span that looked from January 2018 to March 2021, that's right. Interesting note. COVID happened during that time, right? We randomly selected 300 chart notes, which was a mix of in-person and, because of COVID, some tele. It's interprofessional chart notes. So there were some pharmacist chart notes, medical provider chart notes, nursing chart notes, and social work case management, as well as therapy notes that were all in there. And that represented 190 patients. Again, I'm happy to talk after this if you'd like to know more. I will obviously answer what I can. And then if you'd like to learn more, I'm happy to connect you to our brilliant minds that are the heads of the research part. So for the qual part of the qualitative part, basically 2 people pulled all these notes and started reading through them, right? And used an applied discourse analysis framework to be able to identify those themes. And then this is how they created their code book. In comparison, we had a quantitative analysis where we were trying to compare out of the chart, right? What did that look like? What descriptions were similar on the data based off that qualitative analysis that we could look then was that patients who had those experiences, did they have anything in common or anything different? So let's talk about the findings. When we looked at the findings in PS, I looked at the end result. This was separate researchers. This is Sarah's team who looked at the qualitative findings. The first breakdown in those chart notes was that there was stigmatizing terminology, which again, Sarah expected and anticipated that rubric, right? Because we're going to go into the concreteness, which is stigmatizing terms, right? And there was also patient-centered language, right? So those 2 themes, and that those themes weren't necessarily connected over time, and they had some variation. And then in that next analysis that Sarah and Emma did, the next part was a third construct, right? So not only is there terminology or words, specific words that are stigmatizing, and we know across both perinatal and substance use disorder work that those words should not be used, right? And there's holistic, whole person care, patient-centered language. There was a theme in the middle, which is actually language that is non-patient-centered. And that, it's interesting that we were doing this at the same time as Park, that other reference that I mentioned, because Park also was finding this, like, what is this language that is really judgmental and projection of our expectations that changes the tone, right? And as Kaytlin, you said, when you picked up that flyer, you said, I didn't even know it was planting a seed. And I instantly had this like kind of gut punch of like what Sarah and Emma were doing were looking at our chart notes to where our clinical team planted the wrong kind of seed, right? When we use that negative or stigmatizing terminology and then that non-patient-centered language, those are little baby seeds that we are spreading to our other healthcare team, and that the patient may digest as well about themselves, right? So it was really interesting how Sarah and Emma looked through that. I want to give just a quick overview. Again, 300 chart notes. We are not powered to say like this is causation in any way, but it was interesting. Phil, our quantitative researcher, looked at, was there any themes or more prominent findings across these 3 headers, both patient-centered language here on the left, right? And then stigmatizing terminology use versus non-patient-centered language use, right? And it's just interesting. I don't know what this means, right? This is the beauty of beginning research, and any of you are researchers and want to do next steps, yes, please do. Let's do it and let's talk. It's interesting that the chart notes, the people who had more patient-centered language we're in the program longer. The program is pregnancy through 12 months postpartum. And interestingly, had more C-sections. I don't know what that means, but again, it's just something we found. And then the flip to that, when language from this intentional trauma-informed trained team used non-patient-centered language, those patients and participants in the program actually had fewer postpartum visits and less prenatal care. So just in general, less prenatal care, right? And so, right? That's, to me, like, again, this is not causation, but it gives me a gut check of like, ooh, whoa, right? Do we treat people differently when they come less to what we prescribe is the right number of care? I don't need a research study to say absolutely we do, right? And then interestingly, the stigmatizing terminology, did we use them more? The terms were used more often in younger versus older patients. I use that term very loosely, right? So again, just some interesting findings. And this is one of my favorite charts, right? When I look at, so the top line in yellow is patient-centered language over time. The gray in the middle is stigmatizing terminology, and then non-patient-centered language is the bottom line. So as a clinician, this is the chart that made me feel real sad that we have a team that I really expected that line in the middle to just go like up, that we, or excuse me, plummet down, the middle line, that we would use less and less stigmatizing terminology as time went on. We didn't, right? We didn't. We did have a trend that we used less non-patient-centered language and a trend that we did use more patient-centered language. But again, this is not a zero-sum game. These are three separate variables that we're tracking, and certainly that as humans, we all use not interconnectedly. So again, this was the aha. If you notice, the best that we did was like 59% on patient-centered language at the end of 2021's charts. So again, just a real humbling and important pull of the thread on the sweater of assumptions on how we do in this lane. So key takeaways before we go into next steps and function. I want to talk about medical chart notes, right? That they convey clinicians' favorable and negative feelings about people, right? Whether we like that or not. And that the negative perspective towards the patient's choice in health-related and medical care are commonly found even in teams that are setting intention that they won't do that, right? So again, we can, my pull on that is, oh, what's happening in teams then that don't even set that intention? I don't know, right? Frustration and judgment are prevalent in those chart notes, and there's certainly racial and social class stereotyping that occurs. Again, there's that theme of assessment, which is really putting in a power privilege language, and therefore power privilege split between the provider and the patient. And I think, again, this is really a researchy way of saying what Kaytlin just beautifully explained to us, right? So it depends how your brain wants to absorb that information, and objective or subjective data or both. That's what we have for you. So what do we do next? Well, that's what we're going to talk about, right? No one gets real excited, or I personally, maybe someone does, but I personally do not get excited about finding out that what I expected was incorrect, and that there's things that we don't do well without having a plan to try to improve them. And so certainly, again, for those of you who are research oriented on the call, I think there's a lot of work that can be done in this side of the field. But because I'm a clinician and a QI person at heart, obviously our team went to implement trainings to address potentially harmful language used in patients' charts. That's what we're going to talk about next. So again, I know I'm speaking with the choir here, talking about trauma-informed care. This is something you all know about, that these are the tenets of trauma-informed care. Really knowing that there's a lot of debate of whether or not we should still use the word empowerment, but turning over that the patient already has strength and power, and that actually the healthcare system takes it away and tries to give it back, right? Like I didn't mean to put my hands up on my screen then. Choice and voice, right, that don't do something about me without me. I get a voice in that. And then certainly collaboration, again, that's part of voice and choice, that we're doing this together. Safety, again, the Oklahoma Perinatal Quality Collaborative Team, and Catherine just did that perfectly to set that up at the talk, right, that we are dedicated to that, right? We have to have intention around safety. And that trustworthiness, right, that I say what I mean and I do what I say, right, as clinicians is super important. And that this is all of trauma-informed principles are kind of in this cultural, historic, and gendered issued lens or bucket, right? And that it is complex and also important. So when we talk about trauma-informed care, I love to highlight to my fellow healthcare professionals that we don't need to know the trauma to deliver trauma-informed care. In fact, I would argue that unless you are a licensed clinical therapist and you're going to support someone specifically around issues that they want to address about that, we almost never need to know. Again, for those of you who are fellow nurses, I know that's not how we're trained. For those of you who are medical school trained, that is also not how you're trained. We are trained to know every detail, right? And so I love this quote. Feel free to, this is a great, like, I call it the selfie slide, right? Like you don't have to take a picture of you and the slide, but you can if you want. This is a great slide to take a photo of and share and use in something that you're doing education-wise. That the first step to recognizing how common trauma is to understand that every patient may have experienced it, right? We don't necessarily need to question people about their experiences. In fact, there's a lot of literature that supports that that is harmful. And rather, we should just assume that they may have this history and act accordingly, right? That it's just a good rule of thumb, and actually goes back to again what Kaytlin talked about, which is respect and dignity, right? That's where we're at. I think the other thing that shows up in our healthcare spaces is not only when we say, okay, Mel, all right, I'll try that. I don't have to know someone's trauma to perform trauma-informed care, and that I can universally do that. But then what happens when I deliver what I think to be trauma-informed care and someone doesn't react in a way that I expect, right? I think that happens to us a lot. Many of you are inpatient staff, and right, there's nothing like the pressure cooker of inpatient care to really be able to I think spark someone's fears about trauma-informed care and trust. So I just want to hold space that when you think about stigma, and I go back to the very first slide that, right, we were defining stigma from the 60s and prior to that, people who are coming to see you for care, just like Kaytlin, who, and in this context, maybe pregnant or postpartum or anywhere in between, right? They have already experienced stigma from a healthcare provider. And it is not your fault that that happened. And they may respond to you despite your wonderful, loving, very trauma-informed care centered approach in a way as if you are still providing very stigmatizing care, right? Like that you're using that language. And I want to just share with you that may happen and call it out, that that's okay. And we need to be ready for that, because just because one person shows somebody respect does not mean that that is safe for someone to let their guard down, right? The fracture already exists. The stigmatizing language and behavior and expectations have already happened in healthcare, from families, from friends, from peers, on every TV show imaginable that portrays anybody with a substance use disorder, right? So just holding that space, because even when we are showing up in a space that is very trauma-informed intentionality, we have to not hold tightly onto the outcome that we expect of how people will react to that, right? So holding that space. Okay, so Harm reduction is part of trauma-informed care. And many of you on this call may not identify as a harm reductionist. And I want to hold space to that. I want to tell you that I do. I believe in seatbelts. I believe in helmets. I believe that we should all use sunscreen. I believe that if someone is injecting substances, that they deserve a fresh needle in a safe space and someone to use next to, so that, with Narcan. Harm reduction, we so often think about it with interventions aimed at substance use disorders, but harm reduction is actually a much larger concept. It refers to interventions that are aimed at reducing the negative effects of health behaviors that maybe doesn't necessarily extinguish the problematic health behaviors completely. Hence, harm reduction charting. Right? My invitation that we're going to work on next is inviting you to think about, for you, your colleagues, not everyone may believe that people who are pregnant, postpartum, and or parenting with a substance use disorder believe to be treated with respect and dignity. They might not believe that. And my hope is that with harm reduction charting, I want you to work on that piece. I want you to look at it. And in the meantime, I would really love for you to reduce the negative effects of that belief by not promoting that in the chart. How's that sound? We're going to play around a little bit with it and just give you an introduction to the tool. So a pause and throw this in the chat. Have you considered how you talk, and for my nursing colleagues, certainly how we give report, but how you chart and how that may influence how you talk about that patient, how you talk to that patient, how your colleagues read that note and then have perceptions about that patient, right? Feel free to add your experiences in the chat of what that's looked like for you in the past. I think it's something that we don't often talk about. That there's definitely a place for how our work culture may or may not support, right, those charting behaviors, and certainly where we are in the hierarchy of learning, right? And we're going to talk a little bit about that. So here, with going back to Sarah's study and of the charts at Project Cara, and certainly larger data that I referenced earlier, like Park and Himmelstein. When we look at terminology, we're talking about specific words or terms that are used. And we have, I put two great websites on there. There's others, but I think these are really great places to start. Like, how do I know if the terminology I'm using is up to date and not laden in stigma? Right. So NIDA and Recovery Answers, which used to be the Kelly Dictionary. Those are two great resources I have. This is another selfie slide, PS, that you could use. That talks about words matter, gives a list. The NIH, the NIDA part, actually has a great CEU tutorial, right? Like a little training tool that you can use from this website. Again, I love free education, right? Knowledge is power, and we should all have access to it. So this is a great way to do it. But again, we're thinking about specific medical terminology. So substance use disorder, right? That's the correct terminology, right? Urine results as expected, right? Not using the terms dirty or clean, right? Return to use, right? So we're avoiding, again, those other stigmatizing terms that have been part of our vernacular for such a long time, like attic, again, clean, dirty. And we're also have an opportunity to use these terms in patient-centered language. But right now, I want you to think about terminology. In the study that we did, and you'll see in both NIDA and the Kelly Dictionary that turned to Recovery Answers, even things like medication-assisted treatment, we still use that term a lot nationally, and it is not recommended because we don't call like insulin medication-assisted therapy for diabetes, right? It's medication, right? Sertraline is not medication-assisted treatment for depression. It's just medication, right? And so as we get out of the context and the antiquated myth and bias that specific medications, right, that often talk about that with opioid use disorder, but medications for substance use disorder treatment exist in tobacco use disorder, alcohol use disorder, and opioid use disorder, right? We have that stigma and bias that it's one drug replacing another, which it is not. And then that next place over, we have medication-assisted treatment. And so it's time, we're moving over one more space. It's actually medications for opioid use disorder, right? It's actually medications, right? So again, these websites, I think, just are great ways to challenge some of the terminology that we've been taught, right? And how can we improve that terminology that shows better alignment with our ethics, which is respect of the individual. The next piece that we look at is certainly language. This is the example of what Sarah and Emma did with non-patient centered language. And I partnered this with Parks in the negative themes. So we have terminology, and then we have non-patient centered language. So language that conveys that we're impatient, that we had expectations and they didn't meet it. I am dissatisfied, right? Questioning credibility. And I know for those of you who've been in perinatal health for a long time, you're probably looking at this thinking, Mel, this is not just in substance use. This is actually also very much in perinatal health. And you're absolutely right. Again, in this context, we're speaking about it like in the exponential factor that is both. But I definitely want you to pay attention to these terms. Depersonalization, so stereotyping, right? That's a difficult patient. And then unilateral decision making, which it means I'm the medical provider, therefore I'm the boss, and I'm going to tell you what you should do, right? So again, these are all examples of the themes that are non-patient centered language. And then let's do that flip, because again, these are three separate, sometimes overlapping and sometimes not overlapping concepts. Patient-centered language, again, this is whole person care. This is trauma-informed care. And that's, again, just an echo of what we talked about already. So when you're looking at how do I reduce the harm in my language that is used in my charting, we have to hold space that there, right, in the world of electronic medical records, there's three different general ways of which we have language in the chart. One is fixed, right? Whether you're on Athena or Cerner or Allscripts or you name what software platform you're on, there is a set fixed example of language. And it was really interesting, y'all. I'll share with you, I didn't even think about thinking about that. I'm going to say that again. I didn't even think about thinking about that until Sarah and Emma, when they were doing their work on the chart, and they said, Mel, what's this mean? And I was like, oh, that's actually something set by our particular EMR. Like I didn't even choose, like I don't have power to choose that language. None of the clinicians have power to choose that language. It's how the mothership gives us the charting, right? So for example, whether your electronic medical record says that first thing in a chart is history of present illness, or is it chief complaint? And how do those two series of words mean the same thing, but not say the same thing, right? So all of our charts have a fixed component. The second layer is that our charts have a semi-fixed component, right? That there is something that's pre-recorded. This is usually something that's set by the system or the clinical team. So some people may call this dot phrases, drop downs, order sets with more of a narrative language put in it. So there's something that is not set by the software, but yet that's not something that can be edited in real time because it's part of that semi-fixed language and terminology we use in a chart. So again, that's another place when you're looking at a chart note, what happens here, right? And then last but not least, open-ended, which is any place that we, see me typing, free text in a note, right? So that's a free text by, it has, for example, provider here. That could be any member of the healthcare team. And again, that's, again, Mel Ramage shows up today here for an evaluation, right? Any of those open-ended. So holding space that when we think about how we use terminology and we evaluate, have the opportunity to evaluate the charts, not only are we looking for these three themes, but then we're also putting these three themes, knowing the context is, in general, there's three different ways that they can show up in a chart. So I introduce you the very general tool of which we created called the DBARC tool that has that exact concept put in a very easy table, right? Y'all, I'm a big fan of PDSA cycles and atomic habits, right? I need things to be easy for me to do them. I need them just to be like click boxes. I want them to be accessible. I also like them to be rewarding, which means I like to have chocolate when I'm done doing whatever it is that I'm doing. But I want to hold space that this is what we're looking at, right? So this tool is a very easy grid, right? Because if it's hard, we're just not going to do it. So let me give you an example of how we used this tool. So in our outpatient clinic, we have medical students that rotate through the perinatal substance use disorder program, and we get their permission, right? Because we want to role model trauma-informed care. We ask for their consent to participate in what we call the 4-week DBARC tool evaluation, right? Where they're seeing patients with us and doing some of the charting. And through the evolution of 4 weeks, we pick one chart per week to evaluate together, right? And what we're looking for is these 3 themes across, right? These basically 3 headings, right? Is it something fixed? Is it semi-fixed? Is it open-ended? Was something that should have been there omitted? Checkbox. And then what changes do we want to make? And I want to share with you all that the first 4 columns are check boxes only, right? If we think about how our brains adapt to change, right? I think it's really important that we don't have to write down the terminology that we noted, right? We have those references that I shared with you earlier, but I don't want to build and strengthen the pathway that is those terms in that language. I don't want people to write them down. Instead, I want them to spend their time writing down the changes of how you could reword something, right? And so again, in the context of the learner, what we're doing specifically is getting their permission to guide through basically a critical evaluation way to look at their own charting, right? Because at the end of the day, what we want to happen is that people use the DBARC tool on their own, right? We're going to go through some examples because let's be honest, it's always easier to look at someone else's charting than our own. But the goal is actually to have this be part of a natural QI process that is supported at your own facility, right? That once a quarter, charts are pulled for you and you get to perform your own DBARC tool. You don't have to share those results with anybody because again, there's so much shame and stigma around substance use disorder, around perinatal substance use disorder. And certainly there's a lot of shame and stigma when we internally, when we do things that are not as we would hope that we would have presented, right? So I want to hold space yes, go ahead, Kaytlin.
Yeah. I shine in that area. Over a computer, I'm like looking at your screen and then things are popping up. Like I'm taking all these pictures.
Oh, Kaytlin, you just cut out. I want to make sure that anything you wanted to share that you have time to. I don't know if Kaytlin, I don't know if your audio went in and out, but please pop up at any point. So let's take this concept, right, and the goals around it. And again, when we implement this, again, we have lots of intention around it. We want to not only perform our healthcare in trauma-informed centered ways, but also as colleagues work that way. So what would be an example is when people say, yes, I will elect to do this, right? We give them some case examples like this. So if you're all right with it, let's do one together, right? So I'm pretend you were working at an outpatient labor and delivery. For many of you on this call, that won't be a pretend. But you have someone who is a 23-year-old, second pregnancy, had a prior term delivery, shows up at 37 weeks, has a penicillin allergy, our favorite when we're about to do GBS testing, right? Had that previous delivery was a C-section for breech. These are the medications. You notice that this person is on methadone. These are the medical diagnoses that are in the chart. I told you that GBS positive would come up and creep up on us. And these are basically the vitals. And so showing that this person is stable, right? And I want to show you an example of a chart note. And so what I want you to do is read through this note and think about what we've talked about. And what do you notice about this that may have stigmatizing terminology, non-patient-centered language, and patient-centered language. And again, because this is an example, obviously we're not going to look at the fixed, semi-fixed, and open-ended part, right? Because you can't see that part because you don't see the layout of the chart. But I want you to just read this and look at it. And in the chat, if you'll just share yes or no, have you seen a chart note that's similar to this? Yes, always. See some yeses. And I want you to be thinking about, like, where do you see that language, right? And I'm going to take you to the tool next. Where are there some of those terminology, non-patient-centered language, and patient-centered language, and how are they showing up in this chart? So here's an example of some of the things that our team saw, right? See if they match with what you saw as well. You may have seen something that our team did not see. Please put that in the chat because that's the beauty of multiple people, right? Looking at the same problem, right? So chart note review, chief complaint, that's one of those. Again, I promise you, we wouldn't do fixed note versus semi-fixed versus open, but that would certainly be an example of one. And let's talk about language, right? This person, yes, only had, right? Only had, nice job, Megan, only had 3 prenatal care visits. And this person is adamant that they know their body, right? Some are questioning their credibility, right? And that this person is not leaving until she has this baby, right? Right? It's like, and this is not an uncommon description, right? But what are we really saying about this person when we use these terms in this language style, right? Do you all see anything that is patient-centered language? Yes. Yeah. No, knows her body. Sounds like it's going to be a great setup. Like, oh my gosh, I believe you. And then they undo it right with the next part, right? Or even kind of undo it with the word adamant. So it's like a yes and absolutely, right? And today may be in addition to non. That's right. That's right. It may be like today showing up again today, right? Yeah. And that term chief complaint, right? It's how did we even get? I know how we got started on that, but again, like, how is that still a term that we use? Like, hey, welcome to healthcare. What are you going to complain about today? Right? It's just wild that again, this language is so embedded in, and again, that's an example of fixed language. All right, let's do another one. Oh, and let me go back. Someone just said, it's odd that they are using she and they. That's right. And knowing that, again, when we're using patient-centered language, right, knowing the pronoun that patient prefers is important, right? That is also how we use patient-centered language. Yes, absolutely, June. The billing part, right? Focus on the problem because that's where, yeah, that's a whole nother. Do you see I'm pulling down the thread like, all right, Mel, rein it in. Don't talk about we're only going to talk about charting today and not all the things that we have to fix in healthcare. Let's look at this second chart and I want you to put in the chat any of the themes that you notice, whether it's patient-centered language, non-patient-centered language, or stigmatizing terminology. This is in obviously a different electronic medical record because instead of chief complaint, it says history of present illness. So please put in all the things that you notice. Right? Is there a different way to say patient symptoms? Yeah, meth user. Ugh, right? That is not whole person, non-patient-centered language, right? That's stigmatizing terminology and language, right? Not identifying. the person second. Yes, taken no more, right? That's right, Kelly, that language, using the vernacular in a quote is unnecessary and promotes stereotypes. And that is a way that we passive aggressively share with anyone reading this note that we believe this patient is lesser. Park et al. Did a great, like if you want to read more about stereotyping, I highly recommend you read the Park et al. I think they did a great job at really describing that in their literature. So here's just a reminder of terminology. Again, non-patient-centered language and patient-centered language. And again, like you all, here's some of the highlights. And you all, we highlighted some, and then you highlighted even more. Hasn't showed up, right? The patient hasn't showed up. I had expectations, and that person didn't meet them, right? Not only was the vernacular and stereotyping used, and then again, the stigmatizing term of a using the word meth user, and the language, non-patient-centered language that is that. All right, let's do one more before we kind of open it up to questions and discussions. This is chart note number 3. This time we're going to look at assessment and plan. You can probably imagine that part of this would be, it might be a dot phrase or semi-fixed language, right? Where we have kind of that checkbox of like fetal movements, no vaginal bleeding, no loss of fluid or contractions is that acronym that's at the front, fetal heart tones and fundal height. But what else do you see here that may be patient-centered language, non-patient-centered language, or stigmatizing terminology? What do you see? Go ahead and put that in the chat. Hasn't showed up yet. Denies that the results are real. That's right. Patient denies. What else? What else do you see? Dirty urine. That's right. The theme of non-compliance. What else do you all see in this one? So thinking back to our themes, and then in addition to the ones you highlighted, here's some that our team highlighted. How do you all feel about the highlight of inform her of risks of fetal death if she does not follow up? It's an interesting thing, right? We got to call that edge that is, that's right. That scare tactic versus appropriate risk education, right? If we're doing trauma-informed care and we're doing it collaboratively, how we chart that discussion looks really different. That does not sound like a collaborative discussion. That sounds like a CYA. I told you if you didn't do what I said, that your baby may die. And let's even pull some statistics of that. Like that risk of poor outcome may be less than 10%, but I sure charted it like it was 90%, right? Does feel threatening, right? And I have nowhere in this chart do I know what barriers to care that this person may have experienced that affected their participation in care, right? I just have the judgment that they didn't, right? I'm really holding the screening urine that we normally do as more valid than the patient's report, right? Hey, referral to hospital social work, that might be something that's actually patient-centered in here. So we'll highlight that as well, right? But yeah, non-compliant in that judgment and dissatisfaction with the patient note. Again, I know these are charting styles that you all have seen. So I want to go back and just share again with you with what our team has done. And certainly, well, I'll invite collaboration for the future for those of you who are interested. When we look at these charts, again, it's always easier when we do this training to demonstrate through other people's charts. right? And or hybrids. We have lots of hybrid examples that isn't anyone's charting. So no one would be like, hey, I think I wrote that, right? Because that feels yucky as well. But then again, so in this category, what we would use the tool is anytime there's stigmatizing terminology, non-patient centered language, we just put a check in the box. And then, for example, like, how can we reword this? Right. And so in that change section is where we actually take the time to write how we could rewrite these sentences. For example, even methamphetamines addiction, the correct terminology is stimulant use disorder, right? P.S. history of IV user actually isn't even pertinent into this context, right? With assessment and plan. Dirty urine, how could we say unexpected urine for stimulants with no use, right? Sending for confirmation, all those things. So again, knowing that I want to hold space that when we use this tool and do the training that is around this tool, we use some examples that are a little easier to access, that they're not our own personal examples of our own charting. We spend time recognizing, but then we're actually using more time writing what we want that future to look like, right? We are actually using our neurobiology in our favor, where we're building those pathways and strengthening them. That's the goal of the method that we use this. And again, like I said, what we've tried to do is figure out a way to make it part of our QI, and that's what we're working on. Again, this is uncomfortable. It's uncomfortable looking at our charts, and it's uncomfortable taking a look at how we've done things, particularly in the past, right? Because we know we can't change how we wrote that chart note. P.S. It's a legal binding, like it's a legal done document, right? So how can we change that in the future? And how can we be supportive with each other when we're doing this? How can we make it something that becomes an obvious way and encourage cultural way to do this? How can it be attractive, easy, and ultimately satisfying, right? How do we show that that growth for ourselves and ourselves? And again, the end of the day, if someone does not want to change their myth and biases around perinatal substance use disorder, I do ask that we deliver evidence-based care, and that means making sure that we use harm reduction charting. So I'd love to open it up for discussion. I'm going to put this on here in 2025. We are trying to get more work on this tool. So if anyone would like to participate in that, please have our emails. But let's stop the share and open it up, if it's okay, Oklahoma team, for some discussion.
Yes, please. If anyone has any questions or comments they would like to share, feel free to do so.
Okay, I'll share. I mean, this is really interesting because I think, because I work as a therapist in maternal health in an outpatient setting. And, I think we all think that, we're kind of above stigmatizing and things like that. But I think if you really look at your charting, I mean, my gosh, I think it really is a good reflection on how you're really feeling about a client. I mean, this is really interesting to me. I think I like what you said, you thought that your staff that's been so trained would really, you'd see such a difference. But I think if we all went back and looked at our own, I mean, what a way to grow as a person that works within this field. Yeah, because I think it really does would give a good insight. Yeah, definitely.
And do you pronounce your name Jenna or Janae?
It's Gina. Yeah.
Gina. Gina. Yeah. And I think what's so super cool, I mean, again, right. I had to be ready when we did this research study that I might not get the results we wanted, and how cool that we didn't. And like holding space that, again, we were like, it's going to be awesome because we do awesome. And also we had people with lived experience on our team. Right. And so like holding space that there's so many layers that all of us have to look at it, because truthfully we've been programmed, right? We learned how to do from the people who did before, right? And that change, I think it's always possible, but yeah, it's been a very humbling experience, and I think that's been great for us.
Oh, I think it is. I mean, because when I think about, I mean, I think people in recovery or people that are struggling are some of my favorite people on the planet. And I mean, but I think if I went back and looked at my charting, it
You
might
might
tell
not convey that. That's right.
tell a different story.
That's
Yeah,
right. That's right.
definitely. Yeah, very
Yeah.
interesting. I'm going to pass this along. This is very interesting. Yeah.
And again, I for all of you, please, I'm gonna actually pause because June, I just saw you unmute. You go first.
Okay, you know what? This is so exciting. I am one of the old ones that came before you. Do it right. But you know what? I had enough sense, I'm going to say, that I knew that it wasn't right. So I
Mm,
made sure that I did not do it. But you're absolutely right because the tone of your documentation sets precedents for whatever happens after that as far as the interaction of the folks that you work with. And I think it's so great that you all are now taking it up and realizing you have to start there. I love it. This was great.
Thank you, June. You know, and the interesting part, June, like, and I'm curious how you saw that you've seen this over your career. Like, it was really interesting. Like, I really kind of got excited, and in that way that I didn't know what that meant when I got excited. But like on that graph, one of the dips in our the one of the drops in stigmatizing terminology and non-patient-centered care language, non-patient-centered language was actually at one of the heights of COVID. And again, we were not powered to study this. We did not do a secondary analysis to evaluate it, but like what made COVID being a natural experiment, what made that different? Like what changed our stress levels? Because how stressed I am coming into a clinical day changes the way I show up for people, right? And it's going to change how I chart. And like what, like it was just interesting. Like it doesn't necessarily mean I charted better or worse using stigmatizing language, but it might have changed it because again, we saw that bump during
Right.
the start of COVID. And I'm like, what's that about? Right. Did all of us,
Yeah.
were we all so grateful to come into the building that we were on our A game with checking our bias and stigma and language? I don't know, but like holding space that we are humans, that bring our humanness to this work, and we mess it up sometimes, and sometimes we do it great. And what are those factors that impact us as individuals and a group? Like, have you seen any trends with that? Like just looking back at your career?
One of the things I think is that when people came out of COVID, for those that were blessed enough to come out of COVID, I think that there was there was a definite shift, and people looked at things a little different. I think that goes to play that some people changed professions.
Mm.
They had a different outlook. So I do think that there was a change in that, and I'm just grateful, and I'm so grateful for what you all did because I think that that is so very important. And if we don't figure out how to do that a little bit different, we'll continue doing the same thing that we're doing now, which is not doing any good.
Right. Thank you so much, June.
Huh.
Thank you, June. I love this. I've had an almost 40-year career, and yeah, I like to teach about this, and it's very interesting. I'm not so much on the documentation, but the labels that we create about the people for whom we care, and how if I'm holding a label in my mind when I first see someone, that is going to impact how I care for them and what kind of judgment and stigma that may influence my care. And I think it's important for us to be cognizant of those things. I'm not proud of the things that in the beginning of my career, we weren't thinking of this at all. Um, and we were disrespectful talking about patients outside at the nurse's station. And now I think I'm hoping that we're thinking about that and how that is not fair and it can impact our work. And I mentioned the team birth that we're doing in Oklahoma, TEAM. So everybody, because it's not teen birth, it's teen birth. But some of our hospitals have even, it's a standardized communication model for shared decision making and respectful care. And it really, I think, made people think about things like that. And some of them even have a mantra now of, if we're not talking, when we're talking about the patient, we're at the bedside with the patient. We don't talk about the patient in these disrespectful manners outside of the room, unless it's just, information that needs to be shared in a private setting or something like that. But I really appreciate this and what you just gave to us, because I think that it's really helpful to think how we document and what we write is very reflectful of what we're feeling inside. It can be. Or like Gina said, I didn't think it was, but when you look at it, it really is. So thanks for sharing all of this.
Thanks, Barbara. You said that so beautifully. I think for me, when you talked about the team birth initiative that you all are doing in collaboration, I work with a wonderful individual in North Carolina named Alexandra Simpson. And one of my favorite quotes from Alexandra is that the most affected are not the only affected. And so my lens, y'all, I live in perinatal substance use disorder world. And so again, I think how this is just an example of like when we take any dehumanized population in healthcare, like perinatal substance use disorders, right? And we look at how we show up there. I truly believe, and like, I don't think we need, I mean, there is data to support it, but like that impact is actually benefits the larger population, right? That how we can be intentional with our language affects more than just those that we're targeting to show up better for, right? And I want to highlight in the chat, Nicole, thank you for putting this in the chat. Like one of the things I love, one of my QI partners is a real big fan of like, what are you going to do on Monday, right? And this concept that, I mean, I'll be honest, I get roped into it in research. I get roped to it and into it in QI of like, that if we don't have a specific like plan and it's a big written out aim statement and all this stuff, that I can't start doing PDSA work. And Nicole, I think you beautifully, Keith, from my side in North Carolina would love what you said. Like on Monday, if you were at the bedside, you have the opportunity to ask somebody, right? Like, what language would they prefer, right? Hey, I would like to put it, like, you can have discussions and actually start shaping your own journey with people who in real time have a lived experience of the impact of your words. Like, I think we know this so much from so many other ways that we show up with patient-centered language, whether it be pronouns or talking about perinatal substance use, right? We can say, I don't know, and I would like you to teach me how would you like me to write this or how this would go. Now, again, I want to keep that in the context of like, we actually have a lot of medical guidelines on terminology, right? And things like that. But again, we can start having those conversations. Today's Thursday, so you could have the weekend off and start the Monday. Yeah, thank you, Nicole. Other thoughts, comments, ways that you may see this? You might take these concepts and integrate them, right? And I want you to. I want, like, this isn't knowledge and bettering of our human condition should not be proprietary. So, right, like if you find cool ways that you took these tenets and then you did something else cooler with it, please do it. And please obviously share it back with us so that way we can improve how we do it. That's the goal. And then for anyone who's on, again, I look to the Oklahoma team and anyone who wants to do kind of a more formal way of making this more tangible and accessible, which means we have to validate it in 2025, please reach out. I don't know if Kaytlin is still on the call, but Kaytlin,
it looked like she had gotten off.
Okay.
But we definitely thank her and appreciate her words as well as yours, Melinda. Yeah, I just wanted to say when I heard this presentation at A1, it made me stop and think. Like, we talk a lot about the words that we say, but we really haven't really addressed how we document and the things we put into our charts and our patient charts. And that's why I felt so strongly about having that as part of this webinar series, because I think we don't always stop and think about what we're saying in the patient chart, and or as we're reading it, you know, how the examples that you showed were perfect, you know, to help us kind of stop and think like, oh yeah, that really doesn't sound good. You know, I'm sure I've written something like that or seen that 100 times before in my career, you know. So really appreciate those words for sure. I'm going to go ahead and share real quick our evaluation. We would love for you all to just scan the QR code and evaluate our presentation from today. We had some wonderful, wonderful speakers, and we just really appreciate their time and willingness to participate in this webinar series. We just, every time we learn so much. And as I mentioned earlier, we will be sharing the recordings and slides at the end of the series, which will be next Thursday is our final webinar. And that one will be again on Thursday, same Zoom link at 11:30 Central Standard Time. Perinatal cannabis and breastfeeding will be the topic there. So any other comments or questions here? If you're not familiar with OPQIC, feel free to look us up, and you can follow us on social media. We were thinking about, wow, we really need to do some social media posts about how words matter and making that, you know, a focus on things that we look at through our collaborative. So we love that topic that you brought up to us, Melinda. All right. Any other questions or comments in the chat? Just getting a lot of thank yous, and appreciate you again sharing. God, thank you for putting your information in the chat, Melinda. Okay. Well, we're going to give you guys some time back in your day. Again, we thank you all, and we will be sharing the links to these presentations in the coming weeks. So thank you again, and have a great day. Bye-bye.